So, with your permission, sir, I'm starting with today's session. Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for the doctors. Clarnet is delighted to be chosen as the digital partner for this event organized by Indian Academy of Pediatrics, Uttarakhand. So today's focus would be SPA. So without any much further delay, I would like to hand over the session to Dr. Ashish sir to take over. Over to you, sir.
Thank you, Swastika. Uh, 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 I welcome all delegates for this second session episode of our Spark webinar. As introduced last time, this is our endeavor to bring all the medical colleges where post-graduation courses are being held of Uttarakhand under one umbrella. And as we discussed a case last 2 months back, so today we are with the second episode, and for this time the team from SGRR and SMIH, or the Sri English Hospital, will be presenting the case. And without taking further time, I request some IAP representative, if Dr. Hans Vaish or Dr. Sahota is here, to please take over. I think Dr. Rakesh, can you just intro this thing about on behalf of IAP?
Yeah, sir. I'm just my regular practice. So, very well you
Your voice is breaking. I think your signal is weak, Dr. Rakesh. I think Dr. Vaish, Dr. Hans Vaish is here. So, Dr. Hello. Dr. Rakesh, your voice is not audible. May I request Dr. Hans to speak, IAP President, to speak few words before we hand over to
Is it audible now, sir?
Yeah, now you are audible. Yes. I cannot hear you.
Am I audible now, sir?
Sometimes you are getting audible, but it's breaking.
Okay, sir, you can take. Yes,
yeah.
sir, you can proceed, sir.
Yeah, thank you. Thank you, Dr. Rakesh. Now I invite Dr. Hans Vaish, IIP President, Uttarakhand, to speak few words before we hand over to the organizing team. Dr. Hans. I think Dr. Hans also is not able to log in. So, Dr. Vishal, you please, so I invite Dr. Vishal Kaushik, the moderator for today's session. Dr. Vishal, please take on.
Good afternoon, everyone, and thank you so much, sir, for giving us this opportunity. We had a case, we found it that it was quite unique because probably I had seen this case almost after 10 years. So when I was in my last years of PG, so I saw the last case, and then since then I've seen this case now, and we found that still these cases are prevalent in India, although maternal and neonatal tetanus is now gone from India. We have now achieved almost zero cases since 2015, and this is a unique case with, the diagnostic features are only the clinical presentation. So it was a case of generalized tetanus. We would like to discuss this case on this platform. And we also have our director, sir, Dr. Manoj Kumar Gupta. Sir is a known academician, and he's been there previously at AIMS Rishikesh. He has recently joined in as director of Shri Guru Ram Rai Institute of Medical and Health Sciences. I would like to ask sir to say a few words.
Am I audible?
Yes, sir.
Yeah.
Yes, sir. You're audible, sir.
So thank you very much, and good afternoon, everyone. Respected faculty, distinguished panelists, and my young colleagues in pediatrics. I am really truly honored to join you as chief guest for this webinar dedicated to case discussion. You see, one of the most powerful way we learn in medicine is from patient and presenting the case. So at this occasion, first, I would like to give my warm congratulations to the organizing team at SGRRR Institute of Medical and Health Sciences, Department of Pediatrics, and to the executives of IAP Uttarakhand chapter for bringing us together. I will say that webinar of this kind is very important because it involves, number one, clinical reasoning under uncertainty, deciding with incomplete data, balancing probabilities with patient safety. Number two, experts from different institutions who might have different approach to the case in question, and students can learn the expert comments of the faculties of different institutions sitting at their home. The participants hear inputs not only from pediatricians, but also from experts having expertise in subspecialties of pediatrics like neonatologist, eco specialist, infectious disease specialist, etc. In short, I can say that case discussion convert knowledge into wisdom. At this point, I would like to give some tips to the presenter. Number one, in every case, you start with physiology and development before you open the test of menu, long battery of test. Speak to children at their level, listen to caregivers with patients. People remember how we made them feel. Present the case boldly and accept critics graciously. The purpose of the questioning is not to expose you. Remember, it is to elevate you and to keep children safe. If you don't know any answer, say so. And remember that the sentence, "No, I don't know," is the beginning of wisdom and the seed of excellence care. Lastly, I would like to thank the IAP UK chapter for having given me this opportunity. Best of luck to all the learners. Thank you very much.
Thank you so much, sir, for your words of wisdom. They mean a lot to us. And now we would be starting with our case presentation. Dr. Pavitra Shah, our JR2 would be taking over now. Over to Dr. Pavitra.
Good afternoon, everyone. I hope I'm audible.
Yes, you are. Yes, you are audible.
Thank you so much, sir, for your kind words. It's my esteemed privilege to present this case on this esteemed platform. I sincerely thank my college and professors for granting me this opportunity. With your permission, I would like to begin with the case. So I'm here to present a case of a 17-year-old female child, a resident of Pathanpura, Roorkee, who was brought by her father, and the history was given by the father and was reliable. The child was brought with complaints of right ear discharge for 11 days, fever for 7 days, increased tightness of all 4 limbs associated with difficulty in respiration for 5 days, and inability to open mouth for 3 days. The child was apparently well 11 days back until she developed right ear discharge, which was associated. The child was apparently well 11 days back until she developed right ear discharge, which was associated with ear pain, which was throbbing in nature. The discharge was purulent, pale yellow in color, and copious. There were no specific complaints of any foul smelling odor or blood tinge. The discharge was intermittent and there was no significant history of any hearing loss. The child developed fever spikes on day of illness 4, which were acute, undocumented. The parents gave a history of 2 to 3 spikes per day, which were relieved on taking medications but not associated with any chills and rigor. The child was active during the interfebrile period and the child was seeking treatment for the same from a local practitioner. On day 7 of illness, the child developed episodic increased stiffness of all 4 limbs, which lasted from seconds to minutes, and difficulty in opening mouth, which was acute in onset. All 4 limbs were involved at the same time. The child was unable to perform regular activities, which included eating, walking, and even passive movements. The episodic stiffness of the limb was aggravated on stimulus, and the parents also give history of arching of the back like a bow, mostly on any external stimulus like touch. The child continued to have tightness during the sleep. However, the episodes were less. The child was also unable to perform her daily activities and was gradually bedridden by day of illness 10. The child was unable to talk as there was difficulty in opening mouth, however, signaled persistent pain in the limbs. The parents also give associated history of profuse sweating with ongoing illness. Mm. The child was admitted elsewhere where the child was being treated as a case of meningitis, probably acute CNS infection with some IV medications. Neuroimaging and lumbar puncture was not done, and the child was referred to us on day of illness 11 in view of worsening clinical status in the form of increased frequency of tightness of limbs not responding to the ongoing treatment. There was no detailed documentation of the clinical status during the initial hospital stay available. There was no history of headache, vomiting, seizures, or loss of consciousness. There was no history of altered sensorium or behavioral changes. There was no history of any photophobia or phonophobia. There was no history of recent head trauma or any penetrating injury in the recent past. There was no history of animal bites or scratches. No history of sore throat, cough, torticollis, or any swelling in the neck. There was no history of any previous episodes or neurological illness. No history of any known drug ingestion or poisoning. There was no history of deficit in perception of smell, vision, eye movements, facial expression, taste perception, swallowing, hearing impairment, and any abnormal movement of the tongue. Uh, the child is the child is unimmunized since birth, and the parents give no history of vaccination. There was no immunization card available as well. The child has not had any previous hospitalizations in the recent past. The child has attained menarche 4 years back at 13 years of age, and cycles were at regular intervals. Personal history signified a mixed diet with normal bowel and bladder movement and tap water consumption from the municipal source. The child was a term baby, home delivered with birth weight unknown. The child was also a product of second degree consanguineous marriage and was fifth order born. Developmentally, the child has completed education up to 6th standard and has discontinued schooling thereafter. At present, the child was looking after household chores. Socioeconomically, the family belonged to Roorkee and they lived in a Pakka home with 2 rooms and a separate kitchen, and uh, a family consisting of 10 members. And mother was a homemaker and father is a farmer with a per capita income of 3,500, falling under class 3 middle class of BG Prasad scale. To summarize the case so far based on history, Miss X, a 17-year-old female resident of Roorkee, presented with right ear discharge for 11 days and fever for 7 days, followed by limb stiffness and tightness of jaw for 5 days associated with breathing difficulty. progressing to inability to perform daily activities and restriction in movements for 3 days. She's unimmunized since birth, and there's no history of trauma, animal bite, toxin exposure, seizure, altered sensorium. Other systemic, past, family, and menstrual histories are unremarkable. Based on the history so far, a differential diagnosis consisted of meningitis or encephalitis, tetanus, metabolic like hypocalcemia or hypomagnesemia, strychnine poisoning, dystonic reactions, probably drug induced, rabies, or status epilepticus. Can I proceed with the examination?
Any questions till now, or shall we progress to the examination?
I think you first finish the case and then we will take on this
Okay,
thing
sir.
so that the disturbance is less.
Fine, sir.
Examination. On general examination, the child was conscious and anxious and was following verbal commands. At the time of examination, the child was getting into opisthotonous posturing on any stimulation. There was no significant pallor, cyanosis, icterus, clubbing, lymphadenopathy, or pedal edema. On vital examination, the child was afebrile with a pulse rate of 138, normal volume, regular rhythm, and all the pulses were well felt. The respiratory rate was on the higher end with 38 per minute, thoraco-abdominal breathing, and there was increased work of breathing with the involvement of accessory muscles and suprasternal retractions. The blood pressure of the child at the time of admission was 110 by 70 mmHg in the left upper limb in supine position. The child was maintaining a 88% saturation on room air. On head-to-toe examination, there were no significant neurocutaneous markers or rashes or bleeding spots. The hair was normal. On facial examination, the child had a forced smile. Rhesus sardonicus was present. There was no dysmorphism or asymmetry. There was no cataract, ptosis, nystagmus squint. ENT ear evaluation revealed a right ear discharge, which was purulent, copious, non-foul smelling, not bluntage. Left ear was normal. Oral cavity, trismus was present, and cavity could not be examined. Tongue could not be again examined due to trismus. Neck stiffness was present. There was no chest deformity. However, significant tachypnea was visible. Abdomen was suggestive of a board-like rigidity, and organomegaly could not. Abdomen was suggestive of a board-like rigidity. On limbs, there was increased tone in all 4 limbs, and opisthotonous posturing was noted. There were no involuntary movements, and the child was adult appropriate, sexually matured. So this is the image of the child. The initial image is on admission. And in the second image, we can see a very typical rhesus sardonicus. The anthropometry was well within normal limits, where the weight was 51 kg, falling between 50th to 75th centile. Length was 164 as the child could not stand, and was falling between 75th to 90th centile. BMI was 20.256 kg per meter square, 25th to 50th centile. The child was a normal stature child with normal BMI. These are the growth charts and the measurements. To begin with my systemic examination, I would like to start with central nervous system examination as it's my primary system. Higher mental function, appearance and behavior was appropriate, and the child was oriented to time, place, and person. The speech could not be assessed as the child was not able to open mouth. She was trying to speak with a clenched jaw. Higher cognition and memory could not be assessed due to same reasons. Moving on to cranial nerve examination. This is an extensive table, but most of it could not be elicited because of the clinical condition of the child. The significant things have been highlighted in bold, and I'll be talking about them. The fundus, we had got an off-the evaluation done, and the fundus was normal. Trismus was present. Rhesus sardonicus was present. Others, cranial nerves could not be examined adequately because of the clinical condition. The child, on inspection, the child was in spasm with opisthotonous posturing on minimal stimulus. There was no any focal wasting or asymmetry appreciable, no fasciculations noticed. Superficial reflexes, conjunctival was elicited and normal. Abdominal reflex could not be elicited, and plantar was flexor bilaterally. Deep tendon reflexes were exaggerated in the upper limb and lower limb. Biceps, triceps, supinator, knee, and ankle were brisk. Clonus was not appreciated. There was no significant abnormality in the bulk and build of the muscles of any limbs. The tone was 4 plus as per modified Ashworth scale in all the 4 limbs. Since the child was bedridden, the gait could not be assessed. Sensory system was not assessed as any minimal stimulus was causing severe spasms in the child. There was no significant nystagmus noticed. Coordination tests were not accessible due to severe spasm. Spine and cranium appeared normal. Meningeal signs, neck stiffness was present. Kernicks and Bruzzic could not be assessed due to stiffness. Autonomic instability was present. There was severe tachycardia and sweating. And there was no evidence of raised ICP. Moving on to the other system examination, cardiovascular system was insignificant. And upon respiratory system examination, we had a bilateral equal air entry with normal vesicular breath sounds. And like mentioned in the vitals, there was tachypnea with accessory muscle involvement and suprasternal retractions. Abdomen showed a board-like rigidity with no distension. However, bubble sounds were consistent. Musculoskeletal examination showed generalized rigidity with opisthotonous posturing on stimulus. To summarize the case based on examination and history, I think I've already read the examination. I've already read the history. I'll just read the examination summary. Examination showed tachycardia, tachypnea, autonomic instability with sweating, generalized rigidity with opisthotonous, brisk tendon reflexes in all 4 limbs, and intact sensation. Other systemic, past, family, and menstrual histories were unremarkable. Diagnostic impression so far based on history and examination was suggestive of a generalized rigidity with trismus, with opisthotonus and autonomic instability in an unimmunized adolescent child with preceding ear infection, and consciousness is maintained. Most likely generalized tetanus grade 3B. I'm proceeding with the course in the hospital. On day 1 of admission, that is day 11 of illness, the child was admitted in PICU and kept on minimal stimulus environment. Triple HFNC support was provided in view of respiratory distress, and the child was started on infusion diazepam, magnesium sulfate, metronidazole, and augmentin. Tetanus immunoglobulin and active immunization of tetanus was administered as soon as it was available. Patient was kept sedated, and spatula test done was positive. ENT reference was sought, pus swab collected from the right ear, and oral toileting was done. At 24 hours, NG feeds were initiated and with adequate calories and additional requirements. Moving on to day 2 and day 3 of hospitalization, where the child was continued on diazepam and magnesium sulfate infusion. The intravenous infusion of diazepam was escalated to the maximum possible dose for the child for the day. The child was maintained on NG feeds. Autonomic signs persisted despite ongoing diazepam infusion, and there were tachycardia, tachypnea, profuse sweating, and labile hypertension. Despite ongoing sedation, the child continued to have intermittent spasms. On day 4 of hospitalization, the child had clinical worsening with severe sustained spasm. The child required endotracheal intubation and initiation of muscle relaxant along with inotropes. Spasms remained refractory despite maximum muscle relaxant therapy, and the child eventually progressed to a cardiorespiratory failure secondary to autonomic instability. We had gotten investigations, and only the relevant investigations are put. There was nothing significant. We had a elevated CKMB with a HB of 9.9 and counts of 20,600 suggestive leukocytosis. These are generally the factors favoring poor prognosis in tetanus, and the plus sign indicates the factors that are present in our patient at this point. One was a short incubation period. Since the history is only for 11 days, incubation period could not be correctly assessed. But our patient definitely did have a persistent autonomic instability and required ventilatory support and muscle relaxant. Inotropic support started as well, and the child was unimmunized at 17 years of age. Shall I move to the discussion?
I think at this point, is any of the moderators present in the group? Dr. Sharma is here. I think at this point we can have some discussion as to what was the reason for this child not being immunized? Any social particular reason for this?
The family was unaware about the immunization. The family was unaware about the immunization. The previous 5 kids have also been unimmunized.
So, sir,
And
this child was from so this child was from Roorkee, from a rural background, and when we inquired about the immunization status of the rest of the family members, we were very shocked to know that the other siblings, including the parents, were all unimmunized. When asked about the reason, so they literally told us that they were unaware of this immunization and they had not taken even a single shot. The birth shots were even not taken.
This reflects a big failure of our social
Yes, and
awareness
sir, we had
campaigns of
reported this case to the
immunization.
IDSP and to the
Yes.
concerned area so that necessary steps can be
Yeah.
taken.
Yes.
It was very
Secondly,
sad on the part that we
yeah.
lost this patient because uh, we were very at the point of time when the patient was admitted, and only in those days I got a call from you, and
Yeah.
we were very looking very positively towards salvaging this patient, but somehow due to this autonomic instability and deteriorating clinical status, we lost this patient. But yes, this was a very clinical case. The diagnosis was also clinical, and most of our residents, sir, they had not seen this patient or these kind of patient because these are rare entities in nowadays. And probably most of the residents who have joined today's this
Yeah.
program
So,
must not be
uh,
aware of the clinical condition with which the patient of tetanus presents, because this patient, I remember this patient presented in the probably the early hours uh, of the day, and our senior resident who was on duty uh, for first hour probably they were managing the patient according to the symptoms, but they were not very sure of the diagnosis. The first diagnosis that they kept was still meningitis, query encephalitis.
yeah.
And when they characteristically saw these symptoms or the examination, the rhizus sardonicus, those the stimulation with which the stimulation the child was going into the opisthotonous posture, there was trismus. Then they thought of this diagnosis, and
Yeah.
then they managed it on the lines of tetanus, and we did what could be done to the patient, but finally we lost the patient on day 4 of illness.
Actually, nowadays, when we see this kind of patient, we think of rabies more common than tetanus because, rabies, as you know, rabies has become more common than tetanus. So,
Yes,
what were the points specifically pointing towards tetanus in this particular case?
sir, there was typically the rhizus sardonicus. Sir, the background was an unimmunized child, and on that we had the ear discharge, the right ear discharge, with the incubation period. I had read that the incubation period, as per the 22nd edition of Nelson, it is 2 to 14 days. So it was all matching in the clinical profile. Plus, the child had these spasms which were exaggerated on the stimulus. So any kind of stimulus, even when we were putting cannula, the child went into that bow like posture. spreading on the head and the ankles, and it was characteristic of tetanus with risus sardonicus, the opisthotonous posture. There was trismus, the jaw was locked. Initially, we were not able to even perform the spatula test. Once we started with the medications, the relaxants, and eventually we were able to perform this spatula test.
A question has come in the chat box regarding ECG.
Regarding?
ECG. Somebody has asked about how was the ECG? Or
Sir,
whether
we were
ECG
doing
was
lead to monitoring was being done continuously in the ICU, and there were no changes that were observed in the lead 2.
okay. And how easy or difficult was it to procure TTIG?
Sir, actually, we were able to, put the tetanus immunoglobulin only after 12 hours of the admission, because it was not available in the hospital. We had to literally ask to the leading vendors in Dehradun, and finally we were able to find this tetanus immunoglobulin. So
And what was the
we
cost
were
like?
sitting in the center of Dehradun, and we
Yeah.
took almost nearly 12 hours to put tetanus immunoglobulin to the patient.
Any other delegates would like to ask any questions? The topic right now is open for discussion.
Yeah. Am I audible?
Yes, sir.
Yes.
Uh, Dr. Vishal, firstly, thank you for bringing the not so rare, but nowadays rare case for the residents and for the senior residents or maybe some junior faculty to become aware about the condition. Because nowadays, maybe the young generation will find it a little bit difficult because if they haven't seen the case. What was the cause for death? Let me ask the resident.
Sir,
Then let the resident ask.
Uh,
Not for you.
So the cause of death was the child continued on day of 4 despite maximum sedation and despite maximum muscle relaxation. The child continued to have sustained and prolonged spasms. And the clinical condition was worsening in the form of autonomic instability worsened. And the child eventually went into shock where the child required inotropic support along with the mechanical ventilation. So.
Child was intubated, I think. Huh?
Yes, sir. The child was intubated on day
And in
4 of
that
hospital.
case, if you were not able to control the spasm, what else could have been done?
So,
If you are able to control the spasm, how were you able to perform the intubation?
we had actually used propofol, that was a bronchodilator, and we had intubated the child. Once we had intubated the child, we had put the child on central muscle relaxants like atracuronium, where our child was comparatively better than on room as well. However, the child continued to have spasms and autonomic instability worsened with tachycardia, and there was hypertension.
No, if you put child on atracurium, whatever the spasm are there, the child is paralyzed. They should not happen there. So I think if you had intubated, then you can use those paralytic agents, or you can use any other like propofol or some other vitamin. And I was curious why chlorpromazine was not used in the case. Because if you go in the man for the management of the fitness, diazepam, as you rightly have done, was drug and the chlorpromazine, the other drug, which would have been tried. Or if patient is intubated, then for that matter, to control the spasm, you can use anesthetics also.
sir, eventually we did use the anesthetic agents. Initially, we were trying to control the spasms on the drug of choice, that was the diazepam. So we reached to the maximum dose. Then we introduced magnesium sulfate. Once these spasms were not controlled, we used other anesthetic agents, and the child was intubated, keeping all the precautions, using the anesthetic agents, and still the autonomic instability was there. The child persisted to have hypotension, so probably it was neurogenic shock that we were anticipating. We started on the vasopressors also, but then eventually we lost the child.
Okay, but as you have intubated nurse, so you can use, we cannot allow the patient to have the spasm. Once we have intubated, we can use. But
Yes, sir. We could have.
mandatory that,
We could have used that. Even there are other
not
options also
difficult.
available. And
Once
your
airway
point
is
is correct.
maintained,
We could
it
have
is not
used it.
difficult. Sorry.
Sir, your point is absolutely correct. We could have used it, but at that point of time, we had certain other choices also. So we were more inclined to those choices because at the time of intubation, we had already used the anesthetic agents. So we had completely paralyzed the patient at that point of time.
Okay. What about pneumonia aspiration? Was there any component of aspiration pneumonia?
So,
This child treated outside
actually,
also, which would
we
have
were not
further.
anticipating aspiration pneumonia because the child was already on NG feeds first. The second thing is the position was also maintained. And thirdly, the child did not develop any signs of respiratory distress till the time the child was intubated. And also on auscultation, there were no significant findings. So we were not anticipating aspiration pneumonia.
Yeah, that's what happened most of the time. As you told that she was admitted outside also. And, that should also be looked
Sir,
for.
your voice is breaking.
Because
We are
this
not
is
able
one
to
of
hear.
the cause for the mortality in case of fitness.
Sir, your voice is breaking. Probably we are not able to hear what you're trying to convey.
Hello,
Can you repeat the question?
hello, am I audible?
Yes, sir, you're audible now.
Actually, I was saying that the cause for the mortality, aspiration is one of, in these cases,
Yes, sir. It
aspiration
is one of
or
the.
hospital-acquired infection, they are the leading cause for the mortality.
Yes, sir. Sir, the stay
Subsequent
was very short.
spike.
Actually, we lost the child on day 3, 4 of illness. The stay was very short, and sir, the child was not having any, signs suggestive of any hospital-acquired infection. Also, the stay was very short, sir.
Okay, thank you. Please go ahead.
There are a few more questions in the chat box. I'll just read them out. They are all by Dr. Agrawal. One is about precautions taken for intubation. Any specific precautions which required to be taken for intubation? Second is role of magnesium sulfate and any possibility of degenerative diseases, Wilson's disease. So, any response to these questions, Dr.
Sir,
Vishal?
actually, Wilson's we were not anticipating because the history was very short. First, the setting was an immunocompromised child with ear discharge, with the clinical, the findings of trismus, opisthotonus, and the spasms increasing on stimulus. So, the diagnosis was very clear. And also for tetanus, they say that the diagnosis is clinical. You do not need any other evidence apart from this. The spatula test, that is very specific for it. In the initial state, we were also not able to do the spatula test because the child was having trismus. So we were not able to open the mouth of the child to put in the spatula. But once we started with the diazepam for the brief period, we got the child to do that spatula test, and it was positive.
Then there are questions about role of magnesium sulfate.
Yes, sir. Regarding the role of magnesium sulfate, we had multiple purposes in this case. First was a magnesium sulfate was acting like a muscle relaxant by reducing the acetylcholinesterase, and which eventually helped us in somewhat controlling the muscle rigidity and spasm. Second thing, sir, magnesium sulfate also had a role in autonomic stability. So it controlled our tachycardia, hypertension, arrhythmias, and also it had a mild sedative effect, and there was CNS depressant action as well by magnesium. So it served multi-purpose at that
Yeah,
moment.
like we also use it in asthma, severe acute asthma episodes also.
Yes, sir.
Then there another question again by Dr. Agrawal is, any precautions taken for intubation? See, like this patient is susceptible for your autonomic instability also. There's a possibility of aspiration during intubation. So that's why this question is there, that in a sick patient, any specific precautions were taken for intubation. So I'm assuming that you people must have gone through rapid sequence intubation where the conditioning medications must have been given before intubation, and you people must have ensured that child is NP nil orally before you going for intubation. Am I right?
Exactly, sir. We went in for the rapid sequence intubation at the point of time when the child deteriorated, and we took all the necessary steps to prevent all these complications, sir.
Okay. Thank you. And thank you so much, Dr. Agrawal, for all these interesting questions. If there are no further question, I think we can move on with the discussion. Or if there are any questions, please feel free to ask. I think we can move on with the discussion.
Sir?
Yeah.
To begin with the discussion, so a tetanus is a neurotoxin mediated disease. It's caused by, like all of us know, Clostridium tetani, and it eventually causes progressive muscle rigidity, painful spasm, and autonomic dysfunction. Although this disease is entirely vaccine preventable, like our case, it continues to occur in unimmunized population, especially in low and middle income countries. While going through, while reading up about the cases, I happened to come across two interesting studies with respect to tetanus that have happened in India. The first study was by Moderator et al. In Lokmanya Tilak Hospital, Mumbai, and the study was conducted across 10 years from 2009 to 2018. In the study, the 31 pediatric tetanus cases were included over 10 years, and the majority, that is almost 74% of them, presented with generalized tetanus, while 26% had local disease. Spasms, as per the study, the spasms were the most common presenting symptoms. 90% of the patient presented with spasm, followed by trismus and opisthotonus. Autonomic dysfunction in the form of labile hypertension, tachycardia, or sweating was observed in 29% of the patient. Complications included respiratory failure, pneumonia, and sepsis. The overall mortality rate, as per the study, was 19%. We'll come regarding this discussion in the further slides, where we have a mortality of almost 35 to 40 at present in India. But the study was conducted quite some time back, and higher deaths in children who developed early spasm, autonomic instability, and required prolonged ventilatory support. The authors of the study also concluded that timely intensive care, ventilatory support, and control of autonomic dysfunction are key determinants. Moving on to a second study, which is very specific to our case. This study was conducted by PJ Chandigarh, and this is also a 10-year long study over 2006 to 2015. It was published in Journal of Pediatric Critical Care in 2017. In the study, the majority of the cases presented generalized tetanus and required intensive supportive care. The purpose of the study was that the overall mortality in this study was 40%. In our previous study, we had a 19%. In this study, we have 40%, markedly higher than in most recent series. And there was also poor outcome, significantly linked to grade 3B disease. We'll come to grading, and our child was falling under grade 3B. Autonomic dysfunction, need for vasopressors, and absence of intrathecal human tetanus immunoglobulin. The study concluded that despite advances, pediatric tetanus continued to carry a very high mortality rate in India, especially in those with severe disease and autonomic involvement. Moving on to the pathogenesis, the Clostridium tetani spores enter through any traumatic or contaminated wound, and it's not the spores that germinate, it's your vegetative cells that germinate under anaerobic condition, and they produce tetanospasmin, which is a neurotoxin. Toxin binds at the neuromuscular junction, and there's endocytosis into the motor neurons. Following this is a retrograde transport, axonal transport to the spinal cord and the brainstem. The neurotoxin cleaves synaptobremin, which is a vesicle docking protein. And this inhibits the release of a GABA and glycine, causing severe contractions and rigidity. So basically, it acts on our antagonist muscles, and there's a loss of inhibitory control, and the end result is sustained muscle contraction, rigidity, and spasm. Like incubation period mentioned is 3 to 21 days, and it could maybe be months after an injury. It's just a brief diagram showing how a clotrimazole tetany blocks the GABA and glycine, and then this is spasm. So based on phenotype, we have 3 types of tetanus. We have a generalized tetanus, which is most common, localized tetanus, and cephalic tetanus. Generalized tetanus is something that presents early with trismus, rhesus sardonicus, neck stiffness, difficulty in swallowing, painful spasm of the head, back, limb muscles, opisthoronous posturing, and there's also associated with dysphagia, dysarthria, laryngeal, and respiratory muscle spasm. And it can also end up in a life-threatening rigidity, like in our case. There was sympathetic overactivity, sweating, tachycardia, arrhythmia, labile hypertension. Localized tetanus is when spasms are confined near the wound, and cephalic tetanus is most likely associated with otitis media, where there's cranial nerve palsies, and the most common cranial nerve is cranial nerve 7. The diagnosis of tetanus. Tetanus is primarily a clinical diagnosis supported by history and characteristic signs with very limited role of labs and culture. However, we may find some leukocytosis secondary to infection or stress response. CKMB may be elevated because of sustained spasm. However, it's not specific. And electromyography may show continuous motor activity unit. The clinical bedside test, which has a very high sensitivity and specificity, which was positive, is the spatula test, where we touch the posterior pharyngeal wall of the spatula, and there's intense contraction of your mesetal muscles causing biting, or spasm of the muscle causing biting of the spatula. This is the Ablett classification of tetanus severity. We have a grade 1 where there's only mild generalized rigidity. We have grade 2 where we have moderate rigidity, short spasm, but there's no respiratory compromise. In grade 3A, we have severe rigidity, but respiratory compromise is present, no autonomic instability. Our child was falling under grade 3B, severe spasms with autonomic dysfunction. And eventually by day 4, our child progressed to grade 4, which was very severe form of rigidity, spasms, uncontrolled autonomic dysfunction, BP fluctuation, arrhythmia, and cardiac arrest. Treatment of tetanus. This is based on Nelson. So the antibiotic of choice as per Nelson 22nd edition is metronidazole 30 mg per kg per day. If it's not available, alternative, we have a penicillin G, we have amoxicillin. To neutralize the toxin, tetanus immunoglobulin is given. The recommended is 3,000 to 6,000 units may be used, but recent studies have shown a lower dose of tetanus immunoglobulin is still effective. If a tetanus immunoglobulin is not available, then we can go for IVIG as well. The tetanus immunoglobulin that we give only neutralizes the toxin that is circulating in the bloodstream, but the toxin has already crossed the synapses and blocked the neurons. We really don't have a solution for that at present. It can only be controlled by a magnesium sulfate and diazepam, which eventually just reduce the spasticity. This tetanus immunoglobulin lasts for 2 to 4 weeks, and by then our active immunity kicks in, active immunization kicks in. The control of muscle spasm, we have quite some variety available here. We have benzodiazepines. The most commonly used is diazepam and recommended here as well. We give a IV dose of 15 to 40 mg per kg per day, and the effective dose at which your patient is controlled is sustained 2 to 6 weeks before a withdrawal. Then in second option, we have a magnesium sulfate, where we give a loading with 40 mg per kg over 30 minutes, followed by 3 gram per hour continuous infusion. However, magnesium should be given very carefully, and adequate clinical monitoring as well as serum magnesium monitoring should be done. Neuromuscular blocking agents like vecuronium and pancuronium. We also have baclofen, chlorpromazine, and dantrolene. Active immunization, like I had mentioned, needs to be done immediately because this only works for 2 to 4 weeks. Prognosis of tetanus recovery depends on the synaptic regeneration. Basically, natural infection does not induce protective immunity. So the mortality is highest in neonates. We have a 75 to 90% mortality, and elderly. And in generalized tetanus, we have a mortality of 5 to 35%. This is as per Nelson 22nd edition. And in localized tetanus, we have a mortality of less than 10%. Poor prognostic factors, like mentioned earlier, short incubation period, early spasm, autonomic instability, and concurrent infections contribute. Survivors, favorable prognosis linked to long incubation, late spasm onset, and access to a good intensive care may benefit the patient. To wrap the presentation, we also have the very important part, that is wound care. So we need, if there's a uncontaminated wound, we need immediate cleansing, debridement, removal of necrotic tissue and foreign body. Prophylaxis by wound type and immunization history. If it's a clean wound and booster is more than 10 years since the last toxide, we don't need to give. Dirty wounds, booster more than 5 years, we need to give tetanus immunoglobulin if the patient is incompletely immunized. Causes of death in tetanus. We have listed out 5 most common causes that could common causes of death in tetanus, and the most common and the topping the list is respiratory complication. That could be severe laryngospasm causing sudden airway obstruction, spasm of respiratory muscles, and respiratory arrest. And like sir had mentioned, we also have aspiration pneumonia that due to dysphagia and secretions. Autonomic dysfunction can also cause severe cardiac arrhythmias, tachyarrhythmias, bradyarrhythmias, easily, and blood pressure instability. You can have paroxysmal hypertension or sudden hypotension and an arrest. Third in the list, we have secondary infections, mostly pneumonia because of bedridden status, and septicemia in prolonged cases. Exhaustion and metabolic causes, because of severe sustained spasm, we could have rhabdomyolysis causing acute kidney injury, and the spasm can also cause hypothermia, dehydration, and electrolyte imbalance. And with specific to this case, rarely a ear infection can cause an intracranial spread to meningitis and brain abscess. Thank you so much.
Thank you. Dr. Vishal, there are a few more comments on the chat box. So I
Yes,
think we can take them one by one. There's one question that, can you please enumerate causes of clear sensorium with muscle spasm?
so, sir, we had shown you the slide with differential diagnosis that we had kept earlier. So there are so many causes in which we can have muscle spasms with intact sensorium. Tetanus is one of them. Even in strychnine poisoning, you get severe painful spasms triggered by stimuli, and sometimes consciousness is intact. Hypocalcemia, hypomagnesemia, these are the metabolic causes. Even in spinal cord lesions, we can have spasticity and spasms, and sensorium is intact. Uh, Certain drugs like phenothiazines and lithium, they can cause spasms. And one is rabies. In the initial stages, the sensorium is intact, and there are some painful spasms. And heat cramps, sometimes even in conversion disorder, that is quite different. But these are all the differential diagnoses that we had kept in mind while dealing with this patient initially.
After that, there's a comment. It is not a question, it's a comment, that in setting of autonomic instability, I think Maxwell should be used very judiciously.
Sir, there are so many studies that suggest that magnesium sulfate is basically a useful adjunct to CNS depressant being used traditionally. So basically, the sympathetic crisis that is there. This therapy controls the sympathetic crisis, and also there is the suppression of catecholamines. So, in fact, magnesium sulfate is quite useful and sometimes used as the second line drug while dealing with patients of tetanus.
Then one more question is there, that is procurement process of tetanus immunoglobulin. I think it is you covered slightly that there's no as such fixed. Again, you only can.
Yes, sir. Even we were sitting in the center of the city, and it took almost 12 hours to arrange this tetanus immunoglobulin. So, पवित्र कहाँ से मंगाया था?
This regarding magnesium sulfate, the
There is
question has
one
again
Medicos,
come.
that is Ruchi Medicos in Dehradun, and we got this tetanus immunoglobulin from there.
Vishal, am I audible?
Yes, sir. Yes, sir.
This magnesium sulfate question again has come up.
Yes,
So
sir.
the message we should go, chlorpromazine and diazepam are the time tested drugs.
Yes, sir.
I have
They have
managed
been
my
used
all
traditionally and
patients.
over the period of time.
I have managed my all the patients with these two drugs. Even here also, maybe 5-6 years back, we managed the boy. And regarding the safety limit also, what is written in the books at times we have go beyond that. That's why if you protect the airway, you can use higher amount also what is written. So the choice should be, message should be ki chlorpromazine and diazepam. If not available, you can try magnesium sulfate, or the if the patient is intubated, you can try the paralytic agents.
Absolutely correct, sir.
Okay. So, any other comments from any of the dignitaries? Any questions? If there are no further questions, I'll request if any of the external experts, is Dr. CM Sharma here? Their names are not coming very clearly because there are two names with username Sharma, but I'm not sure whether Dr. CM Sharma is there or not. Dr. Ritu message came that she is not able to log in, so she's not here. And so if there are no further comments, then if Dr. Hans Vaish is here, so I'll just request him for a closing comment, and then we can close the session. So I think I think there are no further comments or questions. So I would like to thank Team SGRR for an excellent presentation. It was a common but nowadays not so common disease, and I think it was a very interesting case. So thank you, Dr. Vishal and Dr. Shah, for this excellent presentation. Thank you.
Thank you so much, sir. Dr. Hans is also here. We can take some words of wisdom from him.
Yeah, Dr. Hans.
Hi, I
Yeah.
congratulate Dr. Vishal for this amazing presentation on a very interesting case. I hope all the pediatricians and all the postgraduate students would have benefited from this. And I also congratulate Dr. Ashish Simalti for carrying on this series. Hope we will have more cases in the future. The first case was on rheumatological disorders. This was on tetanus. So we are moving towards all sections of pediatrics. This covered some infections. So thank you all team for this amazing presentation, and hope we continue with the same momentum and zeal. Thank you so much. Thank you all seniors. Thank you, Dr. Utkarsh. Thank you to the presenter. And thank you to Dr. Vishal for this amazing presentation. Thank you so much. Thank you.
Thank you.
Thank you so much.
So, thanks to all the dignitaries present here. Clarity is really glad to have all these brilliant people together in this session today. And I really hope that you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much, everyone.
Thank you, everyone.